Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Clinica Sierra Vista for hosting today's session, Microvascular Complications in Diabetes with Dr. Margo Hudson. Dr. Hudson is an assistant professor of medicine at Harvard Medical School, where she has practiced for nearly 40 years, specializing in endocrinology with an emphasis on diabetes. And we are just super, super lucky to have her as one of our MAVEN Project volunteers. So Dr. Hudson, when you're ready, please begin.
Okay. So thank you for joining. And Kristen and I were just talking about the news about the earthquake. So we hope that everybody is okay and that your families are okay. And the other thing I want to mention is that if you hear vacuuming in the background, it is my cleaning service. So the topic of this talk is microvascular complications of diabetes. And here are the disclosure slides. And here are the objectives. So I hope at the end you can appreciate the full gamut of complications from diabetes, screen patients for these I'm specifically not talking about the vascular complications, but we're talking about the microvascular complications, and recognize treatment approaches for the complications. So we're going to start first with a little bit about the pathophysiology of the microvascular complications, what's understood at this point. Then I'll go into specifics on retinopathy, neuropathy, and nephropathy. And I'll end up with a topic that I think you probably don't know that much about, and that is the musculoskeletal complications. And we're just really at the beginning of understanding how diabetes affects the musculoskeletal system. So this is to just go over a little bit about how does glucose cause microvascular complications. So if you look at this, I hope you can see my arrow, this little cartoon here, just to remind you that insulin binds to its receptor, and it's like a lock and key, and it opens up a channel that allows glucose to come into the cell. Now, this primarily works in muscle, adipose tissue, and the liver to move the glucose into the cell and to activate metabolism of glucose. But other tissues have non-insulin dependent glucose transport. And so in the setting of high glucose levels, their cells are exposed to very high levels of intracellular glucose because they can just freely transport the glucose in. The tissues that seem most sensitive to the effects of high intracellular glucose include retina, kidney, nerve, and endothelium. And we think that the hyperglycemia directly causes tissue damage through oxidative stress, production of something called advanced glycation end products, and increased osmoles in the cells. So this is data from a really classic trial looking at risk of complications in type 1 diabetes and how it related to level of glucose control. This study was done over many years. And what they did was to map out the risk of complications versus the average A1C over time. And you can see the most affected complication from a hyperglycemia and poor control is retinopathy, followed by nephropathy and neuropathy. And microalbuminuria is, of course, a form of nephropathy. And what they calculated was that a 1% drop in A1C would decrease by almost 50% the risk of retinopathy. So this is for type 1 patients. What about our type 2 patients? So there was a large study called the United Kingdom Prospective Diabetes Study that looked at patients with type 2 diabetes early in their course of their disease and looked at macrovascular and microvascular complications. And what they found is relatively similar to the type 1 study, that a 1% lower A1C translated into risk reduction of 43% peripheral vascular disease, 37% for a combination of microvascular complications, and also improved mortality. So what these two studies showed, and I'll give you the data in a second, is that the effect of good control lasts beyond the time when the periods have good control. So what that means is if you take a patient early in the onset of their disease, their diabetes, when they do not have complications yet, and you really help them achieve very good control, the positive effect on the microvascular complications will persist, even if later their blood sugar levels, their A1Cs go up. So this is called, this has been termed metabolic memory. And the implication is that any period of improved glucose control may have lasting benefits for microvascular complications. And we think it's really the cumulative glycemic exposure that is the underlying etiology. So this just shows you a little bit of metabolic memory in these two trials that I showed you. Here we have the trials of the DCCT. Here you can see for the different complications, the risk reduction. So obviously 80% risk reduction would be almost eliminating it entirely. These are the results from the first 10 years when the study was active. So at that time, there were two groups, one with good control, one with poor control. And the good control group, as I showed you, had improved outcomes. What happened is after the study stopped, everybody's A1C really actually went to about 8%. And yet, even for another 10 years, more than 10 years, they still had risk reduction in all the microvascular complications. And so that if you combine the data, you can see that 10 years of good control really had lasting effects. And what happened in with the microvascular complications in the type 2 patients is exactly the same. Here you see the risk reduction at the beginning of the study. Then the study ended. Everybody's A1Cs again went to about 8%, lasted for many years, and yet they still had improved risk reduction for microvascular disease. So there are, of course, beyond glucose, other determinants of complications. Duration of disease, the longer patients have diabetes, the more at risk they are. There's not too much we can do about that, of course. Blood pressure control is important. Lipid control and smoking. All of these also help determine risk for complications. And here is some data from some trials of type 2 patients looking at blood pressure control and lipid control. So the UKPDS, the type 2 study, also had a blood pressure arm where they had what they called tight control of hypertension. We would not consider this tight anymore, but less than 150/85 versus usual, which was above that. And they found in this microvascular risk reduction, again, 37%. In the advanced trial, some of you may have heard of that, another type 2 trial. This was done with patients who had had longer duration of illness. There was risk reduction for nephropathy of 18%. And what's really interesting is there's no persistent microvascular benefit after the blood pressure studies ended. So if blood pressures go back up, their risk goes back up. There's no persistence. As far as lipids goes, a trial called the Accord trial, again, a type 2 trial done in patients further along in their disease, not right at the beginning of diagnosis. They randomized people to fenofibrate and statin versus statin alone. And what I think is really surprising is that this showed improvement in progression of retinopathy with the addition of the fenofibrate. And we probably do not give enough emphasis on this as a treatment option. So now let's move to specific complications, retinopathy. So the Retinal vascular blood flow controls nutrient and oxygen delivery to the retinal cells. Diabetic retinopathy is characterized by occlusion of these vessels and leakage of the vessels, resulting in decreased oxygen delivery. Vascular endothelial growth factor is secreted in response to the capillary dropout and hypoxia. So just remember VEGF as being secreted in response to the damage done to the vessels in the retina. There are well-categorized stages of retinopathy. Stage 1 is called non-proliferative retinopathy, characterized by microaneurysms, intraretinal blot hemorrhages, and hard exudates. Pre-proliferative is the next stage. Also can be called severe non-proliferative retinopathy. And in this stage, patients have visible cotton wool spots, intraretinal hemorrhages in all 4 quadrants, and venous beading. And stage 3, there's proliferative retinopathy, where there is neovascularization and preretinal and vitreous hemorrhages. Diabetic macular edema is thickening of the macula with fluid collection. This is hard to see on our routine fundoscopy, and diabetic macular edema can exist with any of the stages of retinopathy or just has a life of its own. So this just shows you a little bit normal retina. You can see the macula here, the optic disc, arteries, and veins. And here you see some of the various changes: cotton wool spots, hard exudates, dot hemorrhages that we see that characterize diabetic retinopathy. What about the improvement what about the effect of acute improvement in glucose on retinopathy? So this, of course, becomes a big treatment issue for our patients. So what happened in the DCCT, 13% of the patients who already had retinopathy who were randomized to intensive control actually had worsening of retinopathy noted, but it was transient in half the patients and resolved. So what we find is that you can get worsening of diabetic retinopathy around 3 to 6 months after initiation of intensive control in about 10 to 20% of patients with diabetic retinopathy. But those with proliferative retinopathy, it's a much higher percentage, 20 to 40% with intensive control. So this is something to be aware of. So patients who have proliferative or pre-proliferative retinopathy should definitely be considered for treatment prior to initiating intensive management. What about retinopathy in pregnancy? So many studies have documented worsening of retinopathy during pregnancy in patients with pre-gestational diabetes, meaning patients, not gestational patients, but patients diagnosed before they became pregnant. So that's pre-gestational diabetes. So a greater drop in A1C early in pregnancy is associated with greater risk of worsening of retinopathy. Longer duration of diabetes is associated with greater risk, but retinopathy is not a risk in gestational patients. So what do we do in the setting of our patients who have retinopathy, poor control, and we want to improve their control? So we know that there are benefits to tight glucose control, and we can see that at least after 5 years of tight control, it is possible to see some short-term worsening for up to 3 years in type 1 and type 2 patients. So patients who are known to have pre-existing retinopathy need to be followed closely when initiating tight control. It's not a reason to not start tight control. It is a reason to make sure they are seeing ophthalmology. So I just want to emphasize that. It's something to be aware of. So what about treatment for retinopathy? Here is a view of laser. Laser is indicated in proliferative and preproliferative retinopathy. It increases oxygenation by these little laser beam marks. It can lead to a 50% reduction in vision loss, so very effective. But because of the way they do the lasers, you can see there can be some loss of peripheral vision. And it is now considered, lasers considered second-line treatment for macular edema. Okay, sorry, I missed this. So what about inhibiting VEGF? So I'm not sure if you have any patients who have had this. Certainly I have seen patients who get this. So intravitreal injections of VEGF inhibitors have been found to help diabetic macular edema in up to 80% of patients and are the preferred therapy. Use of VEGF inhibitors is effective in up to 60% of patients with proliferative diabetic retinopathy. It's non-inferior, meaning it's equal in terms of efficacy to laser, but there is no peripheral vision loss. One of the issues, it's a very new treatment, so we don't know the duration of effect in proliferative retinopathy. And so patients may need recurrent injections. And inhibiting VEGF is not recommended for non-proliferative retinopathy at this point. So what are basic screening recommendations for retinopathy for type 1? Start at least start by 5 years after diagnosis, type 2 at diagnosis. If no retinopathy, we used to say everybody gets an annual eye exam. Now that has been relaxed. So if patients have no retinopathy, screen every 1 to 2 years. You can have them catch a break that way. If retinopathy is noted, they should be screened annually. And if they become pregnant, they should have screening before pregnancy, if at all possible. They should be screened during the first trimester and if they have retinopathy, each trimester after that, and at least more intensive screening, at least through 1 year postpartum. Okay, so for diabetic neuropathy, up to 50% of type 1 and type 2 patients will develop symptoms of neuropathy. It's responsible for 50 to 75% of non-traumatic amputations. And there's a big disconnect here with neuropathy in terms of effect of glucose lowering. So glucose control will lower risk in type 1 patients. I showed you some of the data by up to 80%, but it does not seem to have as much of an effect in the type 2 patients. It only lowers their risk 5 to 10%. And type 2 patients are somehow different because even those with glucose levels in the pre-diabetic range can have symptomatic neuropathy. Again, I'm not sure if you have had patients complain of symptomatic neuropathy with the diagnosis of prediabetes, but about 5 to 10% of that population will already have evidence of symptomatic neuropathy. So what are the manifestations of neuropathy? So first we'll go over the sensory manifestations. It's typically symmetric. The longest fibers are damaged first, so it's going to affect their toes before their fingers. They can have numbness, tingling, burning, and shooting pains. Physical findings include loss of pain and temperature from damage to small fiber nerves. And for the large fiber nerves, there's a loss of an ankle jerk, loss of vibratory sense. Use the 128 hertz tuning fork to detect vibratory sense. Ones that are higher or lower are not standardized for this. And they also finally can lose monofilament sensation. I'll show you what the monofilament looks like. They can develop clawfoot and hammer toe deformities, which is a late finding. Neuropathic foot ulcers are a late complication, and obviously we're trying to avoid that. They occur at pressure points, as you can see here on this foot. It's not like the vascular ulcers occur at the tips of a toe, whereas a neuropathic ulcer is much more likely to occur where the foot hits the ground. The depth of the ulcer will correlate with risk of osteomyelitis. So the deeper the ulcer, the higher the chance that the patient will have osteomyelitis. MRI is really the best test for diagnosing osteomyelitis. And if patients have osteomyelitis, they really need specialty care and antibiotics. But treatment in general to heal the ulcer is aimed at offloading weight. Charcot foot deformity is a late occurrence of peripheral neuropathy. The pathophysiology is unclear, but it involves local bone resorption. Hang on one sec, I'm sorry. It involves local bone resorption due to inflammation, and it leads to fractures. So you can see what happens is the bones in the foot collapse, and the patient will develop what's called a rocker bottom foot. MRI, again, is helpful for early diagnosis, and the treatment is to offload weight. Some of our orthopedic surgeons will cast a foot like this to help stabilize it. So this is an early stage. This is really when you can help the patient the most to prevent the late complications. The problem is, of course, this could be multiple things: cellulitis, DVT. There are many, many things that look like this. You have to think about it in the right clinical setting and do the MRI. This can show you how bad these foot deformities can get. And of course, because the foot is deformed, they're at risk for these plantar ulcers. And so that is clearly what we're trying to prevent. So Charcot is rare, but if you can catch it early, you can really make a difference. What about motor neuropathy? So there are mononeuropathies. Entrapment syndromes can involve median, ulnar, and radial nerves in the arm. It can involve the superficial femoral cutaneous nerve, also called neuralgia paresthetica, which presents as numbness and tingling in the upper outer quadrant of the thigh. And you may have seen a patient with perineal foot drop, which can occur in patients. And there are also infarctions of the cranial nerves, in particular 3, 4, and 6. The infarction syndromes have an acute onset and frequent recovery. Here is a third nerve palsy in a gentleman. Very rare, but something to think of is something called amyotrophy, which involves the proximal motor nerves of the thighs. It can be unilateral or bilateral. It presents with pain and wasting, can often look like spinal stenosis, and should be distinguished from that. And autonomic neuropathy, really all the autonomic nerve systems can be affected: eyes, abnormal pupillary reflex. Cardiovascular, there's a loss of sinus arrhythmia as the earliest sign. You'll see a resting tachycardia, very common in patients. Later, they can get orthostatic hypotension. In patients with cardiovascular autonomic neuropathy, they have a much higher rate of silent MIs and sudden death. And overall, these patients have 5 times higher mortality than patients without it. So if you can pick it up, it is a marker to really be vigilant on their cardiovascular risk factors. Pseudomotor, those are the sweating, something called gustatory, which is people eat and they start to sweat profusely. I actually haven't seen that in a long time, but it does occur. More common is decreased sweating on the feet. These this can lead to dry, cracked feet, and I'm sure you have seen that. And then patients are more likely to get foot ulcers. GI autonomic neuropathy, gastroparesis, diarrhea or constipation, and fecal incontinence, very, very distressing, of course. Metabolic autonomic neuropathy can result in hypoglycemia unawareness. Patients don't recognize hypoglycemia until they pass out. Urinary tract overflow, incontinence, and sexual dysfunction. Of course, this everybody is aware of. Hopefully, we're asking our patients. Impotence is the big one. Retrograde ejaculation can impact fertility. And in women, there can be decreased lubrication leading to vaginal dryness. So specific treatments for neuropathy, symptom relief for diabetic sensory neuropathy can involve gabapentin. First-line therapy for patients, you can use big doses up to 2,400 milligrams a day. I think we tend to probably underdose patients. Pregabalin has been effective and is approved for dosing up to 300 milligrams a day. And duloxetine also is effective and approved at 60 milligrams a day. So drugs with efficacy but without specific FDA approval can include tricyclic antidepressants. The biggest problem with these, especially something like amitriptyline, is their high side effect profile. And so if you can get away from them and try one of these first, venlafaxine can work. And sometimes this is over-the-counter alpha lipoic acid. It's a supplement. It's one of the few that I think has any data to support its use in terms of supplements. But the trials have all been relatively small. The American Diabetes Association really strongly is against using tramadol or narcotic medications for neuropathy. For autonomic treatments, orthostatic hypotension, compression stockings. If patients have hypertension when supine, use shorter acting blood pressure meds at bedtime. So when they get up in the morning, they don't get orthostatic. And midodrine is effective. For gastroparesis, we really don't have great treatments. Metoclopramide can be used, but you can't use it long-term, unfortunately, because of the risk for tardive dyskinesia. Erythromycin has been used, but again, it's limited efficacy. And there are gastric pacemakers that have been approved, but really not a lot of data on that. And then for impotence, we have the phosphodiesterase inhibitors, of course. So screening for neuropathy, visual foot exam should be done annually. Use a 128 hertz tuning fork, okay? For the vibratory exam, you put it on a bony prominence. Use monofilament if you have it available. Here you have a picture of the monofilament. You just touch the point and push until it bends. Don't do a swipe like that. And then you should record the presence or absence of the findings. Orthostatic blood pressure and pulse should be checked in symptomatic patients. And one thing, again, that we don't really do is ask patients about sexual dysfunction. Okay, now let me turn to diabetic kidney disease. There is a lot of new information. I'm going to try to present some of the newest understanding of physiology because it does relate to current treatments. So just try and bear with me as I struggle through this. So there are two primary markers of diabetic kidney disease. First is persistent albuminuria. So you can measure it by albumin-creatinine ratio, which I think most of us are doing. Hopefully your lab can do that. Or the old-fashioned 24-hour urine for albumin. Normal is less than 30 milligrams per gram. Moderate, which used to be called microalbuminuria, 30 to 299, and severe macroalbuminuria greater than 300. The other measure is a drop in GFR. Now, early on, patients go through a phase of hyperfiltration, but later their GFR can drop below 60, which is CKD 3, and then they progress from there. And just remember that up to 50% of patients with diabetes may have a decreased GFR, but don't have albuminuria. So checking urine albumin is not, just checking urine albumin is not enough, and checking with just a dipstick is not accurate enough. So don't use urine dipsticks. You have to actually send a spot urine. So what happens? Does hyperfiltration mean? We're going to say that in CKD, it can be hyperglycemia can contribute along with hypertension, hyperlipidemia. The hyperglycemia can cause this phase of hyperfiltration, increase in GFR, and then over time, the GFR is dropped and the hyperfiltration decreases to reduce filtration. Albuminuria starts and continues to worsen as the GFR drops. The hyperfiltration will interact with the sodium glucose transporter 2 and the renin aldosterone system to initiate the abnormalities. And let me show you what I mean. So here is a normal tubule. You have the glomerulus here. Sodium and glucose are fully filtered, and they go into the proximal tubule, where something called serum glucose transporter 2 will remove over 90% of the sodium and the glucose, and it removes it in a 1-to-1 ratio. So 1 green glucose to 1 blue sodium. Then very little sodium is presented late to the macula densa in the distal tubule. However, what happens in chronic hyperglycemia? There is an increase in flow through the glomerulus, an increase in glucose presented. The SGLT2 increases glucose transport. By doing that, it also increases sodium transport. So we have increase in sodium and glucose reabsorption. And then this leads to a decrease in sodium delivery to the tubuloglomerular apparatus here, the macula densa. Then the tubule feels that there is decreased blood flow. And in response, it causes dilation of the afferent and constriction of the efferent arterioles, which increases intraglomerular pressure and causes damage to the nephron. So just to review, hyperfiltration is due to hyperglycemia. This upregulates SGLT2, which decreases sodium delivery. The afferent arterioles dilate in response to that. The renin-angiotensin system is activated, and the efferent arterioles are then constricted, giving hypertension in the glomerulus. Nephrons drop out, resulting in more flow through the remaining ones and more hypertension. And so you can see why inhibiting the renin-angiotensin system and SGLT2 may help restore glomerular flow. So in diabetic kidney disease, renin-angiotensin system blockade, you can use an ACE or an ARB, and this is well proven to improve nephropathy, consistent drop in albuminuria, 20 to 50% drop in end-stage renal disease. It is felt that this is in addition to the blood pressure effect. There is sometimes a bump in creatinine that you may notice when you start an ACE or an ARB, and it doesn't impact the long-term benefit. In those patients with hypertension but without albuminuria, you don't have to use an ACE or an ARB. You can use a calcium channel blocker or a thiazide. You would think that doing RAS system blockade for primary prevention would be effective, but trials have not proven that, so it's not recommended. And dual blockade of the renin-angiotensin system by adding an MR antagonist has led to hyperkalemia without mortality benefit. So also not recommended. So what are some non-RAS treatments? Weight loss, the look-ahead trial examined intensive lifestyle versus usual care and found a 31% improvement in progression to albuminuria and improvement in drop in GFR. They postulated that this was due to lower weight, better A1C, and better blood pressure. But other studies of bariatric surgery, which you would think would be the same as a lifestyle, have not shown significant renal outcome improvement. What about SGLT2 inhibitors? This use of this class of drugs is becoming more and more common in diabetics. So it's a 30 to 40% improvement in renal outcomes. Generally, the patients with the best outcomes had pre-existing renal disease. So it is now recommended for type 2 diabetes, if patients have diabetic kidney disease, start an SGLT2 inhibitor. And this is the important part, independent of A1C. If they have it, start a SGLT2 inhibitor, even if their A1C is under 7. Sometimes patients push back on that, but you should do it anyway for their kidneys. So this just shows you a little bit about adding empagliflozin. This is for people who had significant renal involvement, GFR 20 to 45. And you can see that empagliflozin, in terms of going on to have cardiovascular death or renal disease, improved, the empagliflozin had significant benefit for the patients. So now we can use these drugs. When they were first released, the recommendation was not to use for a GFR below 30, but now it's fine to use down to 20. So what are some updates on management? Metformin use in CKD. The GFR is over 45, you can use the maximum tolerated dose. If it's 30 to 44, don't use over 1,000 milligrams a day, and below 30, please stop. As I just said, SGLT2 inhibitors can be used as long as the GFR is greater than 20. And then there's this whole new class called non-steroidal compared to steroidal, which is like spironolactone. So these are non-steroidal mineralocorticoid receptor agonists, of which the one in the US is finerenone, for type 2 diabetic patients who have GFRs over 25. They have normal potassiums, albumin creatinine ratio more than 30, and they're already on maximum tolerated RAS inhibitors. So this is considered an add-on, independent of SGLT2 inhibitor use. I would recommend, if you feel your patient meets all these criteria for adding the finerenone, to talk with their nephrologist to get some advice. So for screening for nephropathy, start in type 1s yearly, 5 years after diagnosis. Type 2, yearly at diagnosis, just like with retinopathy. Spot urine and GFR. We went over what defines CKD. If you get an initial positive result, recheck it to confirm it. And then initiate evidence-based treatments. Let me just summarize that. So ADA has these 4 pillars now. Renin-angiotensin system blockers, we talked about those. SGLT2 inhibitors. Finerenone, that's what I just mentioned. That is one of the pillars to consider. And what about the GLP-1 receptor agonists? We're using those so much for other things. This is recommended for kidney disease as well. And there just was a study came out this year showing that semaglutide improved renal outcomes by 24% in patients with diabetic kidney disease. So, so even though my slide says it's a potential pillar, it does seem to have efficacy for renal outcomes, so it really should be considered to help in patients with kidney disease. Now, to the part of the talk that I feel you probably are least familiar with, soft tissue complications in diabetes. So chiropathy is the term given to limited joint mobility in patients with diabetes. It's felt to be due to the accumulation of advanced glycation end products in soft tissues. It can be manifested by thickened skin and limited mobility in the hands. I'll show you that. Flexion contractures such as Dupuytren's and trigger finger. Adhesive capsulitis. I don't think this is recognized enough as a complication of diabetes, and carpal tunnel. So here is chiropathy, prayer sign. Instead of being, I don't know if you can see me, instead of being able to go like this, the patients really cannot oppose their fingers. Trigger fingers and Dupuytren's, I'm sure you're familiar with. And finally, bone health. So patients with diabetes have increased fracture risk. Type 1 patients have 4 times higher rate of hip fractures. Type 2 patients have double the rate of hip fractures of patients without diabetes. They also, when they do fracture, have more complications such as delayed union or non-union. It's felt that their bone is not good quality bone because they have accumulation of these advanced glycation end products. Those are our enemies. So, as I said, for hip fracture risk in type 2 is almost twice as high. Vertebral fracture does not seem higher. Fracture risk is higher at any given bone density for men and women. A 1% drop in a T-score increased hip fracture risk 88%, so almost doubled it in women, and increased it by 500% in men. Again, it's the advanced glycation end products that we postulate. So because of this, just this year, the ADA really changed their recommendations on bone health. They feel that you should assess fracture risk in all patients with diabetes. You should monitor bone density every 2 years with a DEXA in all patients with diabetes over the age of 65. And you should do this in younger patients who are at high risk, meaning if they have neuropathy and they fall, they're at very high risk. You should check their bone density. You should select medications for glycemic control with the lowest impact on bone density and fall risk. So you're trying to avoid hypoglycemia. Pioglitazone has been shown to increase fracture risk, for example, so it is not recommended. If they're at high risk for fall and fracture, adjust glycemic goals to avoid hypoglycemia. Make sure they have adequate calcium intake and vitamin D. And this is what I think is so new. Consider active treatment with an anti-resorptive or even an anabolic if T-score is less than -2. Most of us use -2.5 as a treatment threshold. So really the ADA is promoting using these agents at a much earlier stage of bone decreased bone density. So what about microvascular disease and its effect on cardiovascular disease? So there's an increased risk for cardiovascular disease by type of microvascular disease. So retinopathy increases risk 24%, neuropathy 34%, CKD, the greatest correlation 41%. If patients have one complication, their risk of cardiovascular disease is up almost 30%, but patients who have 2 or more complications have almost double the risk of cardiovascular events. So this just shows you the interaction of diabetic kidney disease and cardiovascular disease. I want to move this along so we have a little bit of time for questions. Microalbuminuria, so 30 to 300 in your albumin creatinine ratio, increased cardiovascular mortality 74%, macro over 300%, end-stage renal disease. These patients have very high cardiovascular mortality over 20 times, and we see this in type 1 and type 2. And over here, I just want to point out, this was an analysis of the ACCORD trial. I mentioned it. This was a large trial done in patients with type 2 diabetes. This is the cumulative risk of cardiovascular mortality based on their albumin excretion. So the blue, which is the highest risk, shows those patients with microvascular or worse albuminuria. But you can see the green, which is levels that we do not consider to be significant. Those patients still have a higher cardiovascular risk compared to patients without albuminuria at all. So whether we should change our definition of microalbuminuria remains to be seen, but it is a big marker for cardiovascular risk. So how are we doing? We actually are doing better with all our work, especially in chronic kidney disease. That risk seems to be going down. This just shows 5-year risk over time. If you were diagnosed in 2003 with diabetes, you can see your risk of developing CKD in 5 years was quite high. And if you were diagnosed in 2014, this is even before SGLT2 inhibitors, but certainly in the ACE and ARB era, your risk was down about half for developing CKD. So in summary, microvascular complications are driven by several factors, including glucose control, duration of illness, and blood pressure and lipids. Good glucose control early on in disease has lasting effects. Retinopathy has treatments beyond glucose control, meaning blood pressure, lipids, and laser and VEGF. Neuropathy treatments are unfortunately related mostly to symptom relief rather than disease modification. Management of nephropathy is certainly rapidly changing. I can almost change my slides every week. There's something new that comes out. And I do want you to be aware that soft tissue and bone health are impacted by diabetes, and we should be more aggressive as far as bone density treatment goes. So you can look all of this up in the ADA supplement. It is free. And hopefully we have a few minutes for questions.
Sorry, I could not find my way back to Zoom. That was great, Dr. Hudson. Thank you so much. I did see one question so far, but just a reminder that you can type your questions into the Q&A chat box or use the raise hand. First question. If sudden A1C drop adversely affects renopathy in GDM, should we avoid lowering Should we avoid lowering A1C in GDM too fast? What should be the A1C management goal for GDM?
Okay, so for gestational diabetes, meaning diabetes diagnosed during the pregnancy, typically third trimester, sometimes late second trimester, there is no increase. So I'm sorry, there is no increased risk of retinopathy in gestational diabetes. The risk for retinopathy worsening during pregnancy is for patients who had pre-existing type 1 or type 2 diabetes. So those patients should be screened before they get pregnant, if possible, for retinopathy. And if they have retinopathy, they should be followed closely, because we know that good control during pregnancy of glucose is positive effect on outcomes, pregnancy outcomes. So we know it's best for the baby to have good glucose control. But of course, we don't want to worsen existing eye problems. And that's why we need to partner with ophthalmology in those patients who do have pre-existing retinopathy, either prior to their getting pregnant, that would be the best to get their retinopathy under control, or if they become pregnant, during pregnancy, they can get laser, they can get VEGF, all those things are possible to be treated. And so I want to emphasize we need to be aware of this as a complication in patients who had pre-existing diabetes, but not be afraid of it. We still want to control glucose during pregnancy for the fetal outcomes.
Thanks, Dr. Hudson. Apologize for my assistant who gets really excited about diabetes and starts barking. All right. What would be steps to take for patients with elevated ACR but normal eGFR in addition to controlling BG? Try
Oh,
agents in the four pillars. Are ACEIs or ARB safe with severe al
yeah.
told you guys about big words, albuminuria.
Okay, okay. So just to summarize, I think, we'll try and do Kristen a favor here. So I think the question is in patients with normal GFR, but detectable albuminuria, what are our steps in management? So first, those patients should definitely be on an ACE or an ARB independent of blood pressure. And that dose should be pushed to the highest dose tolerable. So if they don't have hypertension, but they do have albuminuria, they may have trouble tolerating high doses of an ACE or an ARB. So you just push the dose as much as you can. I see patients on 2.5 and 5 milligrams of lisinopril. That's not enough, even if it's just microalbuminuria. So it should be 10 milligrams or 20 milligrams, I think, for an ACE or an ARB. Now we feel if patient has type 2 diabetes and albuminuria, and they're already on an ACE or an ARB, you should also add an SGLT2 inhibitor. I think for type 1 patients, adding SGLT2 inhibitors for nephropathy is less accepted. Or we don't really know because SGLT2 inhibitors can also make patients more prone to DKA, which is already a problem in our type 1 patients. So I think for the type 1 patients, adding an SGLT2 inhibitor in someone with normal GFR but albuminuria is maybe a question that you should ask a nephrologist or an endocrinologist, to kind of weigh in on the benefits for the type 1 patient. As far as finerenone goes, I think that's our pillar 3, right? That's very new. People have very limited experience with it. And there's a very narrow window of who should be considered for it. If you think a patient would meet the criteria, you should really consider sending them to somebody who's used to prescribing finerenone. And finally, for the for the GLP-1s as our fourth pillar, those are pretty much good for everybody who is obese for sure. I think it's a brandy new study that just came out about using it for renal indications for a type 2 patient who is interested in going on a GLP-1. I think this would be a reason to push it. I think it's not known for the so that was for type 2. I don't know if I said that right. For the type 1s, I think the role of GLP-1s, again, is not well studied yet.
Thanks. Okay. Next question. Let me just make sure I'm going in order here. Okay. When patients have microalbuminuria and are already on an ACE and controlled A1C, what would be the next appropriate steps if the level continues to trend higher?
Okay. So I think it's easy for the type 2 patients. Again, this is a little bit of a continuation of the last question. I think for the type 2 patients, you're going to add an SGLT2 inhibitor. And that is going to be, even if their A1C is really good, if you add the SGLT2 inhibitor and they're also on insulin, let's say, they could be on insulin, metformin, lisinopril, and now you add SGLT2 inhibitor. You may need to cut back on the insulin dose, or you may need to do something if the SGLT2 inhibitor drops their blood sugars, but you are adding it because of its renal protection. So hopefully, and again, the type 1 patients, first, I think type 1 patients probably, I know you are, I think I'm speaking primarily to a primary care group. I think if you have true type 1 patients, because these questions become so complicated, should you use SGLT2 inhibitor in a type 1 patient, even though it's going to make them more likely to get DKA? I think that really should be a question answered by an endocrinologist. So if at all possible, try and see if your true type 1s can see endocrine, just because these questions are so complicated.
Okay. I have a severely hypotensive diabetic with CAD, SP, CABG, and CVA in past 4 months. Endo recommended no hypertension medication, only on midodrine, Jardiance, metformin, Plavix, atorvastatin. Any recommendations?
So the question is treatment of their hypotension. So the patient's already on the midodrine. Or is the treatment because they also have kidney disease? They're on an SGLT2 inhibitor. They're on the Jardiance, so that'll be good for their kidney disease. If they don't tolerate an ACE inhibitor at all because they get too hypotensive, then you're kind of stuck as far as that goes. And other things that you can do, have them wear stockings. I mean, it is a big problem if they're very orthostatic and very hypotensive with all these other problems, because a stroke patient, you don't want to get up and get too hypotensive. So midodrine, support hose, I think those are the things that's and avoiding hypotensive agents, I think that's the only way to handle that. They're very difficult patients when they get to that stage.
And I would say for any of like those specific cases, great e-consult. You can always submit that onto the Project platform. Okay. Oh, sorry, I'm just following up. It says cannot give ACE or ARB instead. Okay, right, thank you. Okay. Next and last question. I just saw the time. We have 1 minute left and we only have one question left. Perfect. Can you clarify the impact of improving A1C and the progression of retinopathy? My apologies. I thought you had mentioned that acutely the retinopathy worsens when trying to improve diabetic control. Is this correct? If so, why does this occur?
Okay. So first, it doesn't happen. It's only when we initiate intensive therapy in patients, retinopathy worsens in a very small percentage of patients. So I don't want everybody thinking that this is a common occurrence. It is about 10% of patients. If they have proliferative retinopathy, it can be up to 20%. So it's a small percentage. And again, it is not a reason to be afraid of improving their glucose control. If they're seeing an ophthalmologist, I mean, this might be a patient that you improve their glucose control more gently, right? So if they come in and they have an A1C of 9 or 10%, rather than putting them, rather than bringing their fasting blood sugars down below 100 quickly, maybe start with, if you're going to start insulin, for example, start with a lower dose and gradually work up over a couple of months. If the patient is pregnant, you're really kind of stuck, because at that is the one group where you really do need to initiate intensive control, and you need to do it with the ophthalmologist helping you manage the retinopathy. But I don't want people to think that starting intensive control is going to cause retinopathy in anything but a small percentage of your patients. Can you see if I answered that person correctly? It's I don't want to give the wrong impression to people.
I think you answered it. If you did not, please put that. Yes, thank you. Understood. Okay.
Okay.
All right. Well, Dr. Hudson, thank you so much for a fantastic session today, and thank you all for joining us.